Today we will discuss about sinonasal polyps. First of all, we discuss what are polyps. Polyps are non-neoplastic masses of edematous nasal or sinus mucosa. What are types of sinonasal polyps? There are two types of sinonasal polyps. First one is bilateral ethmoidal polyps and second one is the enterocolonial polyps. As you can see in this picture, there is a mass, reddish mass, which is filling the left nasal cavity and protruding from the left nasal cavity. And in this picture, you can see there are bilateral masses filling the bilateral nasal cavities. So, we will discuss about the bilateral ethmoidal polyps and its etiology. First one is the inflammatory condition of nasal mucosa, which is rhinosinusitis, and second one is the disorders of ciliary motility, which is Cartagner syndrome, and third one is the abnormal composition of nasal mucus, which is cystic fibrosis. Now we will move towards the next slide. Next is various diseases associated with the formation of nasal polyps. There are multiple diseases which are associated with the formation of nasal polyps. First one is the chronic rhinosinusitis. Chronic rhinosinusitis are of two types, which is allergic and non-allergic. Both are associated with the formation of nasal polyps. And non-allergic type, also called non-allergic rhinitis with eosinophilia syndrome. Next we move on to the Cartagner syndrome. Cartagner syndrome is a recessive autosomal recessive genetic ciliary disorder. It consists of a triad of cytoinverses, chronic sinusitis and bronchiectasis. So, basic problem lie in the defective movements of cilia leading to chest infections, ear and nose, throat symptoms and infertility. Third one is the cystic fibrosis. Its association is 20%. 20% of people with cystic fibrosis having sinonasal polyps. Cystic fibrosis is a genetic condition. It caused by a faulty gene that affects the movements of salt and water in and out of the cells. This, along with recurrent infections, can result in a buildup of thick, sticky mucus in the body's tube and passages, particularly the lungs and digestive system. So it affects both lungs and digestive system. Fourth one is asthma, 7% is association, and next one is aspirin intolerance. Its association is 36%. There is a symptoms triad which includes asthma, aspirin intolerance and sinonasal polyps. And the most important one, allergic fungal sinusitis. Its association is 100%. Most important. And next one is Young syndrome. It consists of sinopulmonary disease and azoospermia. Next one is Churg-Strauss syndrome. It is also called EGPA. EGPA means eosinophilic granulomatous with eosinophilia granulomatosis with polyangiitis. So, it is a disorder marked by blood vessels inflammation. This inflammation can restrict blood flow to the organs and tissues and sometimes permanently damage them. So, it includes the 5 signs and symptoms. First one is, and its mnemonic is FEGVA, FEGVA. First one belongs to F belongs to fever, E belongs to eosinophilia, G belongs to granuloma, V belongs to vasculitis and A belongs to asthma. And the next one is nasal mastocytosis. Nasal mucosa infiltrates with the mast cells but few eosinophils. As you can see, there are few eosinophils in mastocytosis, but Churg-Strauss syndromes there are abundant of eosinophils. Next one, pathogenesis. In pathogenesis, the normal nasal mucosa of middle meatus and turbinate becomes edematous due to collection of extracellular fluid that converts the normal nasal mucosa into polypoidal masses, polypoidal changes. That polypoidal changes should be sessile or pedunculated, and pedunculated are due to gravity and excessive sneezing. The epithelium of the nasal polyps, if not affected by the atmospheric irritations, it should be. It's covered by us. Epithelium surface should be covered by a ciliated columnar epithelium. And if metaplastic changes occur in exposure to atmospheric irritations, it converts from ciliated columnar epithelium to transitional and squamous epithelium. Submucosa. This is the most important point in formation of polyps. Large intercellular spaces filled with serous fluid plus infiltration with eosinophilic fields and round cells. As you can see, multiple polyps originate from the middle turbinate, ethmoidal sinus polyps, and the next one is the maxillary sinus polyp. We will discuss about this one later. What is site of origin of sinonasal polyps? Multiple sinonasal polyps always arise from the lateral wall of nose, usually from the middle meatus. Common site are uncinate process, bulla ethmoidalis, osteo of sinus, middle surface and edge of middle turbinate. Polyps never arise from the septum and floor of nose. So these common sites, uncinate, there are 3 turbinates present in the nasal cavity: superior, middle and inferior. Polyps should mostly arise from the middle turbinate. And osteo of sinuses are opening of sinuses into the nasal cavity. Bulla ethmoidalis are the large ethmoidal cells, and uncinate process is the bony overhanging which overhangs on the opening of the maxillary sinus. What are symptoms? Symptoms of bilateral ethmoidal polyps are different from the enterocolonial polyps. So mostly symptoms occurs in the adults: nasal stuffiness leading to total nasal obstruction, because total nasal obstruction is due to because these are bilateral. Partial and total loss of smell, because the smell receptors lie in the roof of nasal cavity. So basically the point of origin of these polyps are also from the roof of the nasal cavity. So if that polyps covers the smell cells, perceiving receptors, so patient can't smell. Headache due to associated sinusitis, sneezing and watery nasal discharge due to associated allergy, and protruding mass from the nostril. What are signs? Signs we can find on the anterior rhinoscopy are smooth glistening surface of polyps, grape-like masses, multiple masses, round, oval to round, often pale in color, may be sessile or pedunculated due to excessive sneezing and gravity, insensitive to probing, do not bleed on touch, often bilateral and multiple. Broadening of nose, increase intercanthal distance. Intercanthal distance is a distance between both medial canthases of eyes. May protrude from the nostril and appear pink and vascular, simulating neoplasm. Purulent discharge is due to associated sinusitis. What is diagnosis? How can we make diagnosis? First of all, clinical examination is most important in this point of view. And second one is the CT scan of paranasal sinuses. CT scan of paranasal sinuses is used to exclude neoplasia and bony erosion and to plan surgery. And the third one is the histological examination. Histological examination is most important in people, especially greater than 40 years, more than 40 years. And treatment is should be a conservative and surgical. Conservative treatment includes 2 points. First one is antihistamines and control of allergy. Antihistamines may revert early polypoidal changes with edematous mucosa to normal. And the second one is the short course of steroids, which is also called medical polypectomy in people who cannot tolerate antihistamines or with asthma and polypoidal nasal mucosa. Aspirin should be avoided in asthmatic peoples. Next treatment is surgical treatment. First one is the polypectomy. 1 or 2 polyps which are pedunculated can be removed with snare. Next one is the intranasal ethmoidectomy. When polyps are multiple and sessile, they require uncapping of the ethmoidal air cells by intranasal route. And the next one is the extranasal ethmoidectomy. This is indicated when polyps reoccur after intranasal procedures and surgical landmarks are ill-defined due to previous surgery. Approach is through the medial wall of the orbit by an external incision, medial to medial canthus. And the next one is the transenteral ethmoidectomy. This is indicated when infection and polypoidal changes are also seen in the maxillary antrum. In this case, antrum is opened by a Gladwell-Luke approach and the ethmoidal air cells approach through the medial wall of the antrum. And the last one is the FES, which is most important. Most of the examiner ask about FES in their final examinations. Functional FS is also called functional endoscopic sinus surgery. Functional endoscopic sinus surgery. It is called due to it restores the function of middle meatus. Middle meatus drains most of the sinuses. So it restores the function of middle meatus. So due to that reason, it is called functional endoscopic sinus surgery. Next, we move towards the enterocolonial polyp. The site of region of enterocolonial polyp is arise from the mucosa of maxillary antrum near its accessory ostium, comes out of it and grow in the guana and nasal cavity. Next, it has 3 parts. First one is it originates from the mucosa of the maxillary sinus. This is the maxillary sinus. As you can see, this is the normal maxillary sinus. This is the maxillary sinus cover with soft tissue density. Polyps originates from the mucosa of maxillary sinus, comes out of its ostium and grows in the nasal cavity and guana. Guana is the posterior nasal opening. So this is it has 3 parts. First one is the antral part. Antral part lies within the maxillary antrum, and the second one is the guanal part, which lies behind this part. Behind this part, guanus lies, and the third one is the nasal part. This part is present in the nasal cavity. As you can see, this is the right-sided enterocolonial polyp. As you can see, the left nasal cavity and maxillary sinus is normal. This is the image of eye, and these are the ethmoidal cells. These are the superior turbinate. This is the middle turbinate, and this one is the inferior turbinate. As you can see, this is the maxillary sinus, which is empty, not having soft tissue density, and this is its ostium, and this overhanging process is called the uncinate process. You have to dissect the uncinate process during FES, which is called uncinectomy. The symptoms of the enterocolonial polyps are different from the bilateral ethmoidal polyps. First one is the unilateral nasal obstruction, because it only limited to the single side. Bilateral nasal obstruction, when polyp grows into the nasopharynx and starts obstructing the opposite choana. That's only the reason when bilateral nasal obstruction present. And the third one is the thick and dull voice due to hyponasality. And the last one is the nasal discharge. Signs. On anterior anoscopy, large, smooth, grayish mass covered with nasal discharge. Soft, can be moved up and down with probe because it has a single stalk which comes out from the ostia. So the remaining mass lies in the choana and nasal cavity, so it moves up and down, up and down. May protrude from the nostril and shows pink congested. So in this it tells you that it can be protrude from the nostril. So if it comes out of the nostril, so it become congested due to the obstruction of blood flow. So it become reddish and congested. It may be missed as it grows posteriorly. If it present only in the nasopharynx, it can be missed on anterior anoscopy. And the second one is the posterior anoscopy. Globular mass filling the choana or the nasopharynx. If we do the posterior rhinoscopy by the rhinoscopy mirror, we can see the mass filling the choana or nasopharynx. A large polyp may hang down behind the soft palate and present in the oropharynx. If it becomes so extensive, enlarged, so it hangs down into the oropharynx. So we can see just asking the patient to open his or her mouth. What investigation we should do? First of all, nasal endoscopy may reveal choanal or enterocolonial polyp hidden posteriorly in the nasal cavity. X-ray of paranasal sinus may show opacity of the involved antrum. Lateral view X-ray. Why we done the lateral view X-ray? Because it shows the globular mass swelling in the post-nasal space and a column of air behind the polyp. What are differential diagnosis? A blob of mucus should be present. We can be mistakenly a enterocolonial polyp. So blob of mucus disappear on blowing nose. Second one is the hypertrophied middle turbinate. Middle turbinate is a bony. So if we probe that middle turbinate, it should feel hard and it should feel a pink appearance due to blood flow. And the third one is the angiofibroma. Angiofibroma is a tumor of angio vessels. So it bleeds vigorously. So history of perfuse recurrent epistaxis, feminine consistency, easily bleed on touch. And the fourth one is neoplasm. Fleshy pink appearance. Neoplasm should be a fleshy pink appearance and febrile nature. Tendency to bleed. What will be the treatment of enterocolonial polyps? First one is avulsion. Simple avulsion of the enterocolonial polyp by a snare method. Reoccurrence is uncommon after complete removal. And in case of reoccurrence, Gladwell leukoperation should be done. Complete removal of polyp from the site of origin. So if reoccurrence occurs, complete removal of polyp from the site of origin to avoid the reoccurrence. Endoscopic sinus surgery is now preferred because, as I tell you before, that why it is called endoscopic sinus surgery. So in this picture you can see that a polyp present in the left ethmoidal cells. So it going down and into the nasal cavity due to gravity, and it completely fills the nasal cavity. Polyp reaches the floor of the nose, causing complete nasal obstruction. So this phenomena shows the bilateral ethmoidal polyps, and this phenomena shows a polyp from forms in the floor of the maxillary sinus. As you can see, it grows from the maxillary sinus. It reaches towards the roof of the maxillary sinus, and comes out of the ostia. It erodes the bony erosion around the ostia and escapes into the nasal cavity. As you can see, it fills the left maxillary sinus completely and comes out of the ostia. These three pictures shows how enterocolonial polyp progress, and these three pictures shows how bilateral ethmoidal polyps progress. Next one is a comparison of enterocolonial polyp and the ethmoidal polyp. First one is age, common in children, enterocolonial polyp, and ethmoidal polyp common in adult. Number, enterocolonial polyp solitary, single, ethmoidal polyp multiple. Laterality, enterocolonial polyp will be unilateral and ethmoidal polyp will be bilateral. Origin, maxillary sinus near the ostium, enterocolonial polyp maxillary sinus near the ostium, and ethmoidal polyp ethmoidal sinuses middle turbinate and middle meatus. Growth, enterocolonial polyp grows backward to the guana, may hang down behind the soft palate, but in ethmoidal polyp mostly grow anteriorly and may present at the nares. Enterocolonial polyp size and shape trilobed, dumbbell shape with enteral, nasal and guanal parts. Guanal parts may protrude through the guana and fill the nasopharynx, obstructing the both sides. And the shape of the ethmoidal polyps usually small and grape-like masses. Reoccurrence uncommon if removed completely for enterocolonial polyp, and reoccurrence is common in ethmoidal polyps. Treatment is only surgical in enterocolonial polyp, and about 50% of patients respond to the steroid therapy in ethmoidal polyps. Some important points to remember in a case of nasal polyp. First one is, if a polyp is red and fleshy, febrile and has granular surface, especially in older patients, think of malignancy. Second point is, simple nasal polyp may have a malignancy underneath, hence our polyp should be subjected to histology after removal. A simple polyp in our children, third point is, a simple polyp in our children may be a glioma, an encephalocele or a meningocele. It should always be aspirated and fluid examination for CSF. Careless removal of such polyp would result in CSF rhinorrhea and meningitis. And the fourth point is, multiple nasal polyp in children may be associated with cystic fibrosis, that is also called mucoviscidosis. And the last and main point is, epistaxis and orbital symptoms, if present in a patient with polyp, should always think of malignancy. So this is our today's topic. Thank you so much.